While I'm presenting.
Okay, so I think everyone in this room knows me. I'm Jen, one of the third years, so I'm going to talk a little bit about post-PE syndrome, what it entails, diagnoses, management, surgical options. So as we go through the talk, these are my objectives. I want to kind of define the difference between CTEPH, CTED, and post-PE related dyspnea, which all fall under, that post-PE syndrome. So it encompasses all three things, and it's kind of a spectrum of disease. I want to talk about incidence of disease and who we think develops it based on risk factors and associations. Look at signs and symptoms that are related to all three of these and how they differ and are alike. Look at imaging findings suggestive of CTEPH or CTED, and hemodynamics as well as that. In addition to looking at the imaging findings that are suggestive of that, I want to look at some other things that can kind of mimic CTEPH on imaging. And then how we diagnose it based on testing and diagnostic criteria, and what the different management options are. Primarily surgical, but also procedural and medication-wise for those that aren't surgical candidates. So as I mentioned, it's really a spectrum of disease. So if we think of all patients after PE, some will, completely get better, not have any exercise limitation, any perfusion defects or anything like that. Some will have persistent thrombi. You can see the different colors over here. Report that they have exercise limitations, dyspnea on exertion, these kinds of things. Some you'll actually be able to find measurable limitations in their cardiopulmonary function. So for instance, if you were, to do a CPET, you could see that they have a reduced VO2 max or an increased VE-VCO2 ratio, which will kind of tell you that they have a ventilatory inefficiency. And then, of course, there are the smaller percentage of patients in this spectrum of disease that actually develop CTEPH and have abnormal hemodynamics. So we'll talk a little bit as we go forward about the pulmonary artery flow dynamics and things you can see on echo and right heart cath. As mentioned, as far as gas exchange abnormalities and cardiopulmonary exercise limitations, we'll primarily talk about what you're going to see on exercise testing. And then pretty much the spectrum of disease is characterized by patients complaining of dyspnea, exercise limitation, impaired quality of life, and functional status. And all of this is stuff that they will complain of 3 months beyond treatment, adequate treatment for anticoagulation. So within the first 3 months, you can't call it this. Beyond that, if they continue to have symptoms and exercise limitation or perfusion defects altogether, then you can classify them into that post-PE syndrome and then further classify them into one of those groups, CTEPH, CTED, or post-PE related dyspnea. And we're going to go through kind of the differentiating factors between each. Any patients that have symptoms before their PE, or you think something else gives a better etiology for their symptoms, then you really can't put them into these categories. It's kind of, in a sense, a diagnosis of exclusion. And then asymptomatic patients that have persistent thromboembolic disease don't fit either. So they really have to meet the criteria of exercise limitation and dyspnea, impaired quality of life, and then the hemodynamic derangements. Okay, so the different risk factors that kind of go into predicting once someone has acute PE, will they resolve their perfusion defects, not have any limitations in terms of symptoms, or will they have persistent defects? So some of the clinical factors when we see patients, and I think most of us are pretty used to seeing initially, you know, when we think about a PE, do they have evidence of right heart strain? How big is the thrombus? Is it submassive? Is it subsegmental, segmental? All of these things. And then if there's any delay in anticoagulation, that can contribute to persistent perfusion defects later on. There's some thought that resistance to lysis, so there are patients that, and I think more rarely you'll see, but you'll see that, for instance, get TPA and still have persistent perfusion defects. And part of that is thought to be they have some underlying chronic disease, and then part of that is thought to be impaired fibrinolysis, and they may have some fibrinogen variants. As far as remodeling, those that have kind of abnormal remodeling and don't have resolution of their emboli have increased levels of IL-8, TGF-beta, and impaired angiogenesis. So that contributes as well. And then I think this one probably makes sense to most of you, but chronic inflammation that continues to persist. So if there's somebody that has a chronic osteo, or they have an inflammatory bowel disease, or, you know, underlying infections, all of those things can contribute to chronic inflammation and persistent perfusion defects. Okay, so the definitions of how we define CTEPH, CTED, and post-PE related dyspnea differ. So we'll start here with CTEPH. When we diagnose that, typically it's going to be on right heart cath-based numbers. So you're going to want a PA pressure greater than or equal to 20, a PVR greater than 3 Wood units, and ruling out left-sided disease with a wedge less than or equal to 15. In the setting of perfusion defects on CT, pulmonary angiogram, and again, despite having had 3 months of effective anticoagulation. So you call it that once they've been adequately treated and continue to have issues. So CTED, is essentially they have the persistent perfusion defects, the exercise impairment, the shortness of breath, but they don't meet criteria for pulmonary hypertension. So it's essentially CTEPH without the hemodynamic abnormalities. And then post-PE related dyspnea is probably the most frustrating one for us, because what do you do with it? They don't have the hemodynamic abnormalities, but they still complain of dyspnea and functional limitation, and you can't find any persistent pulmonary vascular disease. Okay, so when we think about the differences between CTEPH and CTED, there are a couple of things that I want to highlight. So again, the biggest thing that we just talked about is with CTEPH, they're going to have the pulmonary hypertension at rest, so that PA pressure greater than or equal to 20 and a PVR greater than 3. Versus CTED, they're going to have all the symptoms and maybe some exercise limitations on CPET, but they won't have the actual pulmonary hypertension component. One thing that you can see on right heart cath during exercise in those that have CTED is they actually can have an increased mean PA pressure to cardiac output slope, which you see right here. And basically what that's signifying is that they really either have increased PVR in the case of our patients that are presenting with post-PE syndrome, or an elevated LV-EDP if they're somebody with left heart disease. But for our purposes, really it's signifying that they have an increased pulmonary vascular resistance, even though they don't quite meet the hemodynamics for CTEPH. Okay, so talking about the incidence of disease and kind of who we find it in, I think the first thing that I want to comment on is that it can be very underdiagnosed, because I think oftentimes what happens is we think of other more common things causing their dyspnea, or they have confounding factors, and then we don't necessarily go down the road of looking for CTEPH or CTED and we blame it on something else. So I think it definitely goes underdiagnosed. But if we look at estimates of the number of new patients with CTEPH and CTED per year, this is from a 2016 study. The true incidence is probably unknown, but we think it's about 1 to 5% of survivors of acute PE. And typically, if they're going to develop this, it's within the first 2 years. It's really rare to see these abnormalities, you know, essentially past 2 years out. It's going to be when it develops. And then it's essentially going to be from unresolved perfusion defects. You can see, if we look at the incidence of acute PE, pretty common, right? We know that, we see that. And then as you go up the chain here to CTEPH, it becomes less and less common. So we think it's about 1 in 200,000, but again, it probably goes undiagnosed. And then those that fit in that category where they have symptoms with exercise but don't meet criteria for hemodynamics of pH, we probably don't really have a great estimate of that either. So just something to kind of keep in mind when you're looking at these patients. Okay, so what do we know from registry data? So when we look at kind of incidence and prevalence and percentage of patients, we look at registries that different countries have and look at each of these kind of categories. So we know that CTEPH represents about at least 19% of patients referred to PH centers, and the prevalence could reach even as high as 38.4 per million inhabitants, with the incidence approaching 5.7 per million inhabitants. So not insignificant, even though there are, many more people that have acute PE and don't develop this. These are not insignificant numbers when you think about it like that. All right, so there are some things that we know that are kind of associated with developing this. There's a few specific thrombophilic factors that are associated. So patients with an elevated lupus anticoagulant or antiphospholipid antibody are one group. Those that have elevated factor VIII or non-O blood group, so more common in people with non-O blood group essentially. And then anyone with inflammatory diseases like IBD that we mentioned earlier, or chronic infections. These are all, known to be associated with that. And then there is an elevated prevalence of the inflammatory disorders with CTEPH. Also things like splenectomy, ventricular atrial shunts, there are some loose associations with. When we look at these risk factors though, it's important to remember that these risk factors are when we compare CTEPH patients to PAH patients. So this doesn't basically catch all comers in the general population and doesn't really give you, tell you who among PE survivors are at higher risk for the development of CTEPH. It's just looking at CTEPH versus the PAH population. So there is some limitation. So things that we can look at when the patient initially presents at the time of their PE versus follow-up that can be predictive of them developing CTEPH. I think we all are pretty used to looking at on CT or echo an RV to LV diameter greater than 1, a PA pressure, systolic PA pressure, greater than 60. These risk factors down here, 1 through 6, fit a CTEPH prediction score, with the big ones I want to highlight being the RV dysfunction that you find initially. And these are often the patients here, right, where we're considering them for ECOS or catheter-directed therapy, and then those that don't get thrombolytics. In follow-up, when you're looking at patients that have RV hypertrophy or NT-proBNP, that can be predictive as well. And then we talked about some of these risk factors for CTEPH. With the CTEPH prediction score, those that basically have all of these or more are those that we consider high risk. Okay, so I'm going to try to make some of these things interactive. This shouldn't be a hard question. What do you guys think are some of the signs and symptoms patients with CTEPH, CTED, aside from dyspnea that I mentioned, present with?
Fatigue,
okay.
low energy.
Okay. Yeah, so we can kind of classify fatigue, low energy, exercise limitation, dyspnea. What else? Think about when these patients typically present. Is it early? Is it late? These can be symptoms or signs on exam. Okay. All right, so essentially the point I want to make here is that they often won't present till late, right? So initially they won't have much limitation, and then as their RV dysfunction gets worse, and they often will present in florid RV failure. So symptoms are progressive dyspnea and exercise intolerance we talked about. Somebody mentioned lower extremity edema, chest pain, syncope. Do you guys know why we see the hemoptysis with this? This disease particularly or specifically? Sort of. So you get bronchial artery hypertrophy, and that's why they end up having hemoptysis. So that is something that I think we don't commonly think about, but definitely keep in your mind when they're presenting. If they have some of these other symptoms and they talk about hemoptysis and they have a history of treated clot, then definitely think about it. And then of course, signs on exam, all signs where we see kind of right heart failure, lower extremity edema, hepatomegaly, JVD, and then some valve abnormalities as well. Okay, so just a little bit more about hemoptysis. I thought this was interesting. So in looking at a retrospective review of lung histology in patients with persistent PH after endarterectomy and those patients who had more distal disease and got transplanted, and then we looked at their vasculature, they compared in this study these patients to a CTEPH model in platelets. And so if you look we're going to look at the pulmonary vein, microvessel remodeling, and bronchial artery hypertrophy. In the right upper lobe, these are vessels that essentially were unobstructed. In the right lower lobe, they repeatedly embolized an area, and then in the left lower lobe, they completely ligated the vessel. And you can see that essentially there's concordance, right? So very minimal remodeling in the right upper lobe where there's no obstruction, right lower lobe where there is some repeated embolization, and then the left where they completely ligated. So definitely concordant, and tells us that they have abnormal remodeling and then get some hypertrophy associated with that. This is what it looks like on histology. So on this slide, what you're seeing here is blue ink filling the artery and how thick the wall is there. So much thicker than you would expect to see, much more hypertrophy. These are bronchial arteries and veins, sorry. And then on this side, you see the veins, and they have green ink within them. This is kind of the cross-sectional view of this septal vein, and essentially what you're seeing again is abnormal remodeling and thickening of that. Okay, so I think this is the best way to think about why these patients present so late. So early on, before they have symptoms, usually what's happening is their PA pressure is rising, their PVR is rising, but the right ventricle essentially is still compensating. It's trying to dilate and contract and maintain their cardiac output. And then with time, as the PA pressure and PVR continue to rise, you start to see the cardiac output fall off. And this is really when they start to become symptomatic. Ideally, if we could catch them here, we could prevent some of the decompensation. And then when they get really severe, they can essentially be in decompensated RV failure. And this is actually when you see the PA pressure start to fall too, because now essentially they can't even mount any contractile force out against that high PVR. So oftentimes we'll find them here and here. We really want to try to think about it, when they're in the kind of very mild symptom phase before anything's decompensated. Okay, this doesn't have to be like X-ray conference, but if you guys could comment on what looks abnormal in this X-ray to you. Doesn't have to be super formal, but what stands out to you guys about this X-ray? This is a 45-year-old guy with a PA pressure of 38. Okay, I heard someone say right heart border. What else do you see? Right heart border is okay. I think what's really prominent here on the right is the size of the right main pulmonary artery. And you can even see kind of some strandy stuff down here. Versus when you look at the left upper and mid lung fields, you don't see that, right? And when you look side to side symmetrically at the right and left main pulmonary arteries, there's a clear difference. And then what about on the left over here? This is a 44-year-old woman with a mean PA pressure of 43. What do you guys see over here? Here's the aortic shadow. That looks okay to me. Yeah, so right in here, essentially what you're seeing is coming off as the right descending pulmonary artery, and it kind of tapers off as you head towards the pleura. And you can see this in something called pruning. I don't know if you guys have heard of that, but essentially you have rapid tapering of the vessels from that vascular remodeling, and you can see pleural disease. And this cuts off the base here, but this patient had pleural disease in both bases and prominent descending pulmonary arteries. Kind of hard to see on the left because of where the heart's at, but you can also see, as someone mentioned, a big RA and kind of a generous right heart border. Okay, so on echo, what do we see? Thank you. So we can see normal here, right? Abnormal, very abnormal. So RV hypertrophy, what else? What's going on here? The RA is huge, right? That clearly is big. What do we see in terms of the function of the right heart? Yeah, so that's perfect. So we'll see reduced RV function, right? It'll get overloaded, hypertrophied, and then it'll actually flatten out and bulge into the left side in severe cases, right? So when they're in severe RV failure, they can actually impair filling on the left side. And then the bottom, I'm just showing parasternal lungs as well, normal and abnormal, but I think the most prominent one here is to see kind of the degree of right atrial enlargement they can get, RV dysfunction. And then there are measurements that we'll look at later. So I think you guys mentioned all of these. Okay, so I just wanted to highlight a few things when we look at the echoes and the right heart protocols and the values to kind of look at and what they signify. So I think most of us are familiar with the fact that your right ventricular systolic pressure, in the absence of any pulmonic disease, gives you an estimate of your PA pressure, right? Your systolic PA pressure. And so you can see here abnormal less than 30, or sorry, normal less than 37, abnormal greater than 37. So it just gives us a sense of how high that PA pressure is when we're using echo as a screening tool before we get to right heart cath without directly measuring it. And then another value to look at is the tape C. Do you guys know what that represents or what we're looking at when we measure that? Okay, so it's a mouthful, tricuspid annular plane systolic excursion. So essentially what that means is, and it's probably best seen in your apical four-chamber view, you're looking at a kind of one-dimensional measure of RV systolic function. So you're looking at the movement of the annulus at end diastole and end systole, and essentially seeing how much does that annulus move and how much longitudinal contraction do you have. And it gives you a sense of RV ejection fraction, actually approximates at about 80% sensitivity. So something we'll commonly look for. Some, let's say a value less than 1.6 or less than 1.8. Here we're kind of getting concerned when it's less than 1.8 to 2. I think that's what we kind of often look at. And then normal greater than 2. So something to look at. And then our PVR rate is just our measure of pulmonary vascular resistance. And you guys know how we can calculate that? So if you take your mean PA pressure and you subtract your wedge, right, so your left-sided pressures over your cardiac output will give you a sense of what their PVR is. And there's two different ways. It can either be in Wood units or dynes. I think more commonly we're used to looking at it in terms of Wood units. And so we typically consider abnormal when it's greater than 3. Okay, when we see these patients, oftentimes they won't have much abnormality in the sense of their PFTs. They may have an isolated diffusion impairment because of those perfusion defects, but we don't often see obstruction or restriction. If you do see any of that, the restriction is more often from any amount of scarring in the lungs, and the obstruction can actually be from essentially bronchial artery hypertrophy, and vascular hypertrophy enough that it starts pushing on the walls of the bronchi and causing an obstructive type of picture. But most commonly, you're just going to see an isolated diffusion impairment. But just something to note. So when we think about testing for this, VQ scan is really the best. You can see here what I wanted to highlight is how much better the sensitivity of a VQ scan is compared to a CTPA for detecting CTEPH. So clearly a much better measure. However, again, there are mimickers. So if you have a VQ scan that's, intermediate to high probability, you're still going to want to follow it up with CT or angiogram and look at things and see, is this really CTEPH, CTED, or is there something else causing the obstruction of the vessel, essentially? So here we're looking at a VQ scan. You have your perfusion images and your ventilation images, and you're seeing two pretty large size perfusion defects that are mismatched when you look at the ventilation images on this patient. So this is a 35-year-old guy with CTEPH. I just kind of wanted to highlight what it would look like. And there are different ways in terms of orientation that they look at it when you do the VQ scan. So you may have like more oblique imaging or rotation, but essentially you're looking for mismatched defects, areas where there is ventilation but not perfusion. So any ideas, knowing that anything that can essentially compress the arteries could cause this type of picture on a CT scan or imaging? Can you guys think of anything besides CTEPH that could mimic it? Okay, how would sarcoid do it? Okay, yeah. That's a possibility, or scarring. Any kind of fibrosis, right, can scar down, cause compression. So fibrosing mediastinitis can, you're right, terrible lymphadenopathy can. What else? Nodules by themselves shouldn't do it. Again, if you had a lot of scarring, you could potentially see that, but not rheumatoid nodules by themselves. But rheumatoid can pretty much do anything in the lung. So if it was causing a lot of scarring, that's a possibility.
Any other cause of PAH?
Okay. Yeah. How about things like large vessel vasculitis? More rare things like a pulmonary artery sarcoma, basically anything that's going to obstruct the vessel inside or outside, right? So extrinsic compression from any vascular malformations, AV malformations, or from parenchymal lung disease itself and things like fibrosing mediastinitis. So not things that I commonly think of as mimickers, so just something I wanted to bring up. Okay, so when we look at angiography, I just wanted to kind of show some highlights here. In this slice, we're seeing collateral bronchial arteries. You really shouldn't see them, but because this patient has such advanced PH, you can see that. Here, you're seeing an enlarged main pulmonary artery and then an actual perfusion defect right here. You see this one fills all the way and this one doesn't. This is called mosaic perfusion. So you have areas that aren't perfused versus areas that are perfused, and it almost causes, it looks kind of like the mosaicism we see with asthma and air trapping, but just keep in mind vascular disease can do that as well. And then you can see down here just kind of an eccentric occluding thrombus. So just different findings that you can see. So there is something called SPECT CT, and you're essentially combining CT and VQ scan, and it's slightly more sensitive than VQ scan by itself. I don't think it's something we really use often because usually we can figure out what we need by VQ scan itself, but it's something to know that's emerging. On the top here, you have SPECT VQ, and then on the bottom, you have CT scan. So you can have CT that won't show you anything, and then, in the smaller vessels, and then you get VQ scan and you can see these defects. So looking at this one, you're seeing right apical and anterior defects on the SPECT CT VQ and the VQ, but not on the CAT scan. The role of MRA in delineating this disease, we really don't have enough data or studies for to compare it to CTA, VQ, all these other things, including pulmonary angiogram. And it's important to know that on MRA, you don't see the vessel wall very well. It's not delineated. And so it's really less sensitive for picking up like wall adherent thrombuses and abnormal thrombi remodeling that we see. So I think there's going to need to be more studies done before we determine if this is something we could use. So just showing MRA images and then angiogram images. And the other thing is with MRA, you may pick up some of the big vessels, but when you get out more distal, it's not good for picking that up. All right, so we talked about this kind of early on, but diagnosis, hemodynamic-wise, what did we say that the hemodynamics, PVR, PA pressure, and wedge should be? What are we going to see on a right heart cath? About 15. Perfect. So just kind of a reminder of what the different tracings look like, right? Your right atrial tracing, what the normal value is and location of your catheter, the ventricular tracing, your PA pressure tracing, and then your wedge all the way out. So essentially your definition for PAH, right? Okay, so when we think about these patients, oftentimes I think we do this step where we look for other etiologies. We get PFTs, we get EKGs, get some blood work, see if they have an elevated BNP, look at a CTA to see if they have emphysema, sarcoid, parenchymal lung disease, which is all fine. You do want to look for things that could confound the picture. But if they fit, the persistent dyspnea after 3 months of adequate treatment, then you really want to screen them with the transthoracic echo. So if their echo basically is low probability and it doesn't look like they have PH, their RVSP is normal, no RV dysfunction, then you really should be looking for other etiologies. If it's lower probability but kind of intermediate borderline, then you can continue along that pathway and get a VQ scan and see what the probability is there. The VQ scan is negative, then they kind of fall into that frustrating category of post-PE related dyspnea that we really don't have a great sense of what to do with. There's some thought that pulmonary rehab can help these patients. The other thing you can do, which I think I talked about with CTED, is get CPET, so you can look for abnormalities on that. And there are characteristic abnormalities of that. So that being the reduced VO2 max, giving you a sense of reduced cardiac output. They can have a reduced peak oxygen consumption and then increased VE to VCO2 ratio, kind of telling you that their ventilation is inefficient. So even though they may not meet the hemodynamic criteria, they could have those abnormalities on CPET and perfusion defects on their VQ, and then you can put them into that category of CTED, which matters because that will change your management. And then over here on this side, right, their TTE is positive. They have some right-sided changes and elevated PA pressure. They have a moderate to high probability VQ, or if we're doing SPECT VQ, and then you essentially proceed right to right heart cath. And if they do meet hemodynamics, then you're going to send them to a referral center for pulmonary thromboendarterectomy. Okay, so as just mentioned, the gold standard treatment really is surgery because it's the only thing that's curative that we have right now. So when we think about who would be a good surgical candidate, the decision to proceed with surgery on someone is kind of based on 4 different factors. Any ideas of what those factors could be?
How central the shot is the big one.
Good. Yeah. So the more peripheral and more subsegmental you get, the less likely you're going to have efficacy with thromboendarterectomy. Okay. So basically surgical accessibility of the clot. Is it kind of main lobar segmental, or is it very distal and subsegmental? So that's one. I think it's kind of an obvious one, but do they have hemodynamic derangements? At this point, you've worked them up and they do, and so you're sending them. So how bad is the hemodynamic derangement? Can they survive surgery? Is it earlier on? That's something to look at. What other comorbidities do they have that could impact their surgical risk, which I think is something we think about with all our patients. Yes, they have this, but do they have lung disease that would preclude this, or more advanced left-sided heart failure, or something else that would make their mortality so high you don't think it's an acceptable risk? And then, of course, whether or not the patient agrees to do this, which I think sometimes is the one we struggle with, where we see those patients that are good surgical candidates and they just don't want to have surgery. And you know that it would be curative for them, and you just can't convince them to do it. And then these patients are best served at centers, right, that are experienced with this. So we send them to U of M, but more commonly the most well-known one in the country is San Diego, right? So send them there for surgery, essentially. All right, when looking at the risk assessment for these patients, those that do better or have a lower risk of surgery and a good long-term outcome is those that are functional class 2 or 3. I think it probably makes sense to you guys that if your functional class is 4, you're higher risk and probably not going to do as well. The damage may already be done. Something that I thought was interesting is having bilateral lower lobe disease is actually predictive of a better outcome. And then on the other side, you don't have disease in the lower lobes, less predictable of a good long-term outcome, and then worsened hemodynamics, which I think makes sense. All right, so how do we classify these patients surgically? This is again from UCSD because it's a big center that has come up with the data for a lot of these patients. So level 0, no evidence, really, why would we be sending those patients? Level 1, basically, do they have disease in the main pulmonary arteries? Level 2, does it start at the descending? Level 3 is segmental, and level 4 subsegmental. And again, that matters for accessibility and how well those patients are going to do afterwards. If you have a patient with just subsegmental, it's probably not the patient that you're going to be using this therapy for. But if they have main or lobar disease, then they're going to benefit more. So these are just examples of kind of an acute thrombus that was extracted, and then you can see the difference here, slicing open the vessel, how fibrotic and organized this thing is and attached to the medial layer of the artery. So really has been there for a long time and had a lot of remodeling, and those are much harder to remove. Some of the complications of pulmonary thromboembolirectomy, big word, our pulmonary artery steal syndrome that occurs in about 70% of patients. And essentially, you know, for so long you've had poor blood flow to an area, you're going to all of a sudden open up and redistribute blood flow from well-perfused areas to now areas that all of a sudden are going to be better perfused, but do have that remodeling. And so you can see some shortness of breath, some pulmonary edema. This is typically going to get better over time and happens in the acute period right after surgery. And then reperfusion pulmonary edema, same kind of simple thing. All of a sudden you're giving more blood flow to areas that really weren't well perfused before. And this occurs in a lower percentage of patients, about 30% of patients. Mortality for these patients is pretty low. If they survive more than 3 months after surgery, most of those patients are going to be alive at 3 years. So essentially, if they get through that acute period, most likely they're going to do well. And that's really why you want to send them. We know we have good data to show that 12 months out, both their mean PA pressures and their PVR are down a lot. Let me get the percentage here. So the PVR improvement is usually a fall of about 65%. Other things you'll see is that they'll have improved 6-minute walk, testing, improved exercise capacity, and you'll actually see that oftentimes you repeat an echo, their RV function will get better and they'll have reverse remodeling. So really important, that's why we do the surgery on these people, or send them for surgery, I should say, is because it's really going to change the course of their life symptom-wise and their RV dysfunction. And so it tells us that if we can take care of this, obviously the changes aren't always permanent. So other treatment options, or I should say, things you should also be doing. So these patients are going to have to be on anticoagulation for life, right? If they have the degree of clot where you're sending them for thromboendarterectomy or have PAH and CTEPH, they need lifelong anticoagulation. If they're in that category that Asif was mentioning with more distal disease, those are the patients we should be thinking about balloon pulmonary angioplasty. And so that's usually a staged procedure. You go in with a catheter and then a balloon over that wire and essentially break up the webs of clot. But again, that's a very small subsegment of patients. And U of M definitely does this, so that's one center that send them here. And then the only medication approved for inoperable CTEPH, you don't think your patient is, you know, a candidate, or the patient adamantly refuses any type of procedure. We know that riociguat does improve symptoms and exercise capacity. So I just wanted to show this picture of balloon pulmonary angioplasty because I think it kind of shows you how the procedure works. So you have in the subsegment here of the 10th segmental artery, you have plaque. You see adherent to the walls, you go in with the wire, open up the balloon, and essentially, I guess for lack of a better word, crush or push that against the wall of the vessel. So unlike thromboendarterectomy where you're actually taking it out, here you're not taking it out, you're just breaking it up and trying to stop the remodeling that's happening. And then this is essentially instead of improved blood flow on a pulmonary angiogram after BPA and better venous return. So both inflow and outflow get better. So for your more subsegmental disease, think about this procedure. Complications that I think make sense. I mean, you're essentially inflating a vessel, inflating a balloon within the vessel, so you could cause vascular injury. In severe cases, hemoptysis. You could have perforation of the wire. Contrast that's associated with this can cause renal dysfunction. You can have allergic reaction to contrast. So all stuff that's directly related to the procedure or the contrast agent you're using itself. Although these are pretty rare. Okay, so this is the CHEST 1 study. Essentially, they looked at, I want to say 261 patients that had persistent PH after thromboendarterectomy or were inoperable, and they randomized them to either riociguat or placebo. You can see here that there is definitely an improvement from baseline. So what we're looking at as our primary outcome is the change from baseline in their 6-minute walk distance from 0 all the way out to 16 weeks. So in the riociguat group, we see an improvement in about 39 meters in their 6-minute walk, and on hemodynamics, their PVR actually goes down too. For those that got placebo, they actually had a drop in their 6-minute walk distance by 6 meters, and their PVR went up. So this is kind of the big study that led to using riociguat as potential medication for those with inoperable or persistent perfusion defects in hemodynamics after endarterectomy. Okay, so we talked about the diagnosis, once you've confirmed it, you want to send them to a CTEPH center. If they can get surgery, it's acceptable risk, the patient's willing, then you want surgery, they should be on lifelong anticoagulation. If they are too risky or distal, and not an operative candidate, then you want to think about these other things, balloon pulmonary angioplasty, riociguat, and then in rare cases, consider lung transplant, essentially. So it's just a grading of the level of evidence, but I think it's important to look that we have good evidence for lifelong anticoagulation, operability, and then riociguat. So those, just kind of to know, are the big things we should be thinking about. And then kind of lower level evidence for balloon pulmonary angioplasty, but still there. And really that's going to be a very specific subset of patients that you're going to consider for. It's really those non-operable ones or that have an unfavorable risk-benefit profile for having an open surgery. So just some cases to round things out. So we have a 57-year-old guy, history of hypothyroid, splenectomy, had a motor vehicle accident, that's why his spleen was taken out. Distant history of provoked DVT, comes in with dyspnea on exertion. He's got a diffusion impairment, enlarged pulmonary arteries on his x-ray, enlarged RB, and a mean PA pressure of 55 on his echo with reduced function as well. So not rocket science. What's the diagnosis here? Okay, so what would you do with this guy? You're thinking it's CTEPH. What are you gonna do to work it up? Right heart cath, and what else? Okay, so he has a VQ scan. It's high probability, undergoes right heart cath, and essentially his hemodynamics are consistent with CTEPH. So then what would you do with this guy, treatment-wise? Yeah, so do you see any reason that he wouldn't be an operative candidate? Nope, so essentially this guy gets pulmonary thromboendarterectomy and lifelong anticoagulation and does well. Just kind of variants of the different syndromes and spectrum of disease. So now you have a 63-year-old gal, Crohn's disease and diabetes, comes in, same symptom, dyspnea on exertion. She has normal PFTs, normal X-ray. Echo doesn't show you any hemodynamic derangements, but she has a CPET that does show you decreased exercise capacity, increased dead space ventilation. So her diagnosis is CTEPH, perfect. So what would you do with this patient? What are your options? So this patient should still have VQ also. You should still be looking for persistent perfusion defects. So in this case, the patient had intermediate probability VQ, had a pulmonary angiogram showing persistent perfusion defects, and underwent treatment with pulmonary thromboendarterectomy as well, and required lifelong regulation. This is probably the most frustrating case where you have a 48-year-old guy, history of DVT-PE provoked by surgery, happened in the last year, adequately treated for 3 months with anticoagulation, really just some hypertension, hyperlipidemia, and coronary disease, comes in with exertional dyspnea. You can't find anything abnormal on his PFTs, a CPET, X-ray, CTA, anything. What do you call this guy? Yeah, post-PE related dyspnea. And really all we know what to do with these patients is pulmonary rehab. You don't have a ton of treatment options since you're not finding the perfusion defects or the hemodynamic derangement. And then references. Questions? Thoughts? Stop sharing it or look for comments. Comments? Q&A. Okay, so we're good?
Yeah, I think so.
All right.
I
So go ahead, whatever you want.